ما عادش تذكر لنا الباب. الشاب اللي دخل هلا ما عادش تذكر لنا الباب. كم الساعة؟
12:03.
كيف حالكم جميعا؟ Did you miss me? Yes. Do you remember me?
Yes.
اليوم حنبدأ بشيء أحلى من الMSS كثير.
أحلى من الأساسي.
You've started already talking about the different components of the cardiovascular system. And today we're going to start with the pharmacology of one of the most important topics. Yet it's a little bit complex. And we're not going to be understanding it with regards to the pathophysiology of it in detail. You'll learn more about that when you go towards the clinical year. Because as you can see, the topic of our lecture today is going to be about anti-arrhythmic drugs or anti-arrhythmic agents. So we're going to talk a little bit about arrhythmia. Introduce it to you. Did you learn about arrhythmia in physiology?
No,
Next lecture? Okay. Well, so what did you learn so far in physiology?
Conduction system, AV bundle.
Yeah, conduction system, AV bundle. So we have these here. You see, what is this? Yeah, baby. So this is the SA node. So did you learn about how the action potential is produced in the SA node? And then we have here, what is this? The AV node. And here, the bundle of this. So we have the right and left branches. And then Purkinje fibers. And then we have multiple branches of this electrical system. So you learned about the electrophysiology of the heart, right? What else did you learn about? Okay, so we talked about some of the ECG. You talked about the ECG. The lab for the ECG?
No, not yet.
No, not yet. Okay. Inshallah, next week. So we're not going to be covering all of the things you talked about in physiology. You learned these in detail. We will be reviewing them though a little bit. So. ممكن نتحرك الشارع. Fine. I'm going to hold this in. So what do you think are cardiac arrhythmia? We're going to be talking today about the definition of cardiac arrhythmia, the etiology, some of the different types of cardiac arrhythmia, and some of the pathophysiological processes that occur during cardiac arrhythmia in order for us to understand how can we treat these problems. And we're going to talk about the different treatment modalities. Some of these treatment modalities are pharmacological, while others are different. They're not all pharmacological. And hopefully, by the end of next lecture, we'll be almost, or hopefully we'll be covering all of the pharmacological drugs I have in my study. There are other drugs that belong to the general family that I will be talking about, but we don't have time to explain all of the drugs that are available in the market. But we're going to be talking about the different classes and how do these classes work. So let's start with the definition. Who can define arrhythmia for me? Excellent. It's an abnormal heartbeat. So we have an abnormality in the electrical conduction system of the heart. So what kind of abnormalities do you think we can have? Okay, so excellent. Your colleague Khaled has an electrolyte imbalance. So this is actually one of the predisposing factors or one of the etiological factors that makes a person more prone or to develop an arrhythmia. But let's talk about a cardiac sequence of events. So we have the SA node, right?
Yes.
So we can, what do we call the SA node? Pacemaker. And you've learned about the action potential, right? What is different in pacemaker cells and other cardiac cells?
There's a leakage current.
And the leaky current, yes. شو كمان؟ calcium channel. شو كمان؟ ما في plateau. Yeah, I want one word that you really mentioned.
They act like neurons, but they're not.
Neurons. شو كمان؟ ممتاز. شنو auto independent, so they have automaticity. اللي هي independent, you are right. So we have problems sometimes with the automaticity. So these problems lie probably in the SA node. So what does the SA node? It initiates the action potential. It initiates the signal for the whole heart to contract. So it's gonna develop or initiate the heartbeat. What's the normal heartbeat?
70 to
بدنا نحكي range. Let's talk about range.
60
60 to 100. Excellent. مين حكى 60 to 100? Excellent. So if we have anything that's not within this range, it's going to be abnormal, right? So what is the abnormal with regards to 60 to 100? Below 60, what do we call that? Excellent. This is bradycardia. And above 100, tachycardia. And with regards to arrhythmias, so arrhythmias, if we have problems in the rate of the automaticity of the SA node, we're going to either have an increased rate, so bradycardia we call bradyarrhythmia, or we have a decreased rate below 60, and so tachycardia, so above 100, tachycardia or tachyarrhythmia, below 60, so bradycardia or bradyarrhythmia. So what are cardiac arrhythmias? We have disorders of the rate. This is the first type that we talked about. Make sure I cover everything. And the next thing, we said we have the SA node and then the AV node, the bundle of His, the Purkinje fiber. We're going to just focus about the general or the main components of the electrical system. So we have this sequence of event that occurs. So if we have a problem of this sequence of event, we're also going to have a problem in the heart contraction. So also another kind is the sequence of conduction, or the conduction as your colleague said. Or sometimes some other areas of the heart become irritable. They start to produce an action potential. They start to have automaticity. They have that potential in them. يعني. Sorry, مش عارفة بدي أضل. Let's try it. Okay. So, إذا بدون مايك تسمعوا؟ No? Okay, well, I'll try it in a bit. Just let's see how it goes now. So, the cardiac cells, under circumstances, can have the potential to become pacemaker cells. So they can have automaticity. What kind of circumstances? A lot of circumstances. One of the most important ones, or no, one of the most common ones that you've heard of. Did you hear about any of these? Hypokalemia, for example. And others. There are certain conditions, there are certain drugs, there are certain pathological conditions that will tell a cardiac cell, non-pacemaker cell, to start acting like a pacemaker. So in this case, we have problems in the origin of conduction. So these are the main categories of cardiac arrhythmias. Now, another kind of classification, and let me just go through the slide a bit. So the disorders can range from benign to life-threatening. So when we talked about the SA node, we said we can have tachycardia or bradycardia, tachyarrhythmia or bradyarrhythmia. Sometimes these can be asymptomatic and they arise in certain instances. So they do not require treatment. We call these benign. So they're not showing signs and symptoms with the patients while we have these conditions happening. In this case, we sometimes prefer not to use pharmacological treatment. Why is that? Because arrhythmic drugs, how do they work? They alter the movement of ions in the cardiac cell. All of these drugs can aggravate or generate arrhythmias. So antiarrhythmic drugs, although they are used for the treatment of cardiac arrhythmias, they can predispose or generate arrhythmia in certain instances, at certain doses, or with certain drug interactions. So we have to keep that in mind. So we do not prefer to use antiarrhythmic agent unless we have to. And there are a bunch of conditions where we have to use them, and we're going to be talking about these. Now, so we have talked about the term bradyarrhythmia, tachyarrhythmia. Bradyarrhythmia is less than 60, tachyarrhythmia is more than 100. And we have other terms we're going to learn. There is a term called flutter. Flutter is where we have ectopic generation of an electro gradient or electrical signal in the heart from an ectopic site. What do we mean by ectopic site? A site other than the SO node. But still, it is regular. So, it is producing a tachycardia. Flutter means we have increase in the contraction of the heart, so it is still producing a tachycardia. It is regular. Why am I focusing on regular? Because this is different than another term that's called fibrillation. Fibrillation also we have tachyarrhythmia or tachycardia that is present in ectopic sites, probably more than one point. And because we have these different sites generating automaticity or electrical cardiac potential, we have irregularity. And we call that fibrillation. So we probably, when you're reading about medicine or internal medicine books, or you've watched a video, you've heard the term AFib. Have you heard that term? AFib means atrial fibrillation. So what do I mean by atrial fibrillation? This is another classification I want to tell you about. So let's look at our heart here. Of course, we have these two atriums here, and these are the two ventricles. So if we draw a line here, anything above that line, atria, we call it supraventricular. And this is another term you probably heard. Supraventricular, it's above the ventricle or above the line between the atria and the ventricle. So it's also the same or synonymous with atrial, okay? And then we have also sometimes these problems happening in the ventricle. So we also have other different subcategories of arrhythmias that happen in the ventricle. We can have ventricular tachycardia or ventricular fibrillation or ventricular flutter. So all of these are different kinds. Now we don't have the time to try to explain the differences, the pathophysiological differences, but I taught you about the general. So a tachycardia can increase in the heart rate or tachyarrhythmia. Now it can happen at a regular rate if it happens in an ectopic point or foci in the heart, if it's producing a regular rhythm. Now what do I mean by a regular rhythm? Remember the ECG? Did you ever see an ECG? Yes. So we have the P wave, QRS, and T wave.
Yeah.
So now we have sometimes disruption. We said we have tachycardia, so these waves become more closer to each other. Sometimes we have disruption in one of these patterns. Now if we have a disruption that's associated with the tachy rhythm, but it is regular. What do I mean by regular? So the distances between, let's say, QRS, the R and the R is the same. We say it is regular, but it's still disrupted. So sometimes we have missing P waves and we have missing T wave. We have a disruption, but if it's regular, we call it flutter. If it is dysregular, we call it fibrillation. This is just a simple explanation of these different terms that we're gonna be talking about. So what are the types? We're gonna go back and talk about the etiology in a bit, but what are the types of cardiac arrhythmias? Again, we have abnormalities of impulse formation, so rate disturbances, tachyarrhythmia, bradyarrhythmia, triggered automaticity where non-cardiac, where non-pacemaker cells become pacemaker cells. And then we have also abnormalities of impulse conduction. And we're going to a little bit focus on some of these. So we know we have the AV node, and this is conducting or transforming the signaling between the atria and the ventricle. We can have a block there, or we can have a block anywhere in the heart. And these blocks sometimes can cause the formation of something called re-entry cycle. So we have the action potential or the electrical activity keep going on in the same point over and over again. So what is the etiology or the causes of cardiac arrhythmias? We have cardiac causes of arrhythmias, and then we have non-cardiac causes. Some of the cardiac causes include what your colleague has referred to, electrolyte imbalance, because as you remember, as you have learned in physiology, we have important electrolytes, normal electrolytes involved maintaining resting membrane potential, sodium, potassium, and calcium. These are the three main important ones. And these are the ones we're going to be messing around with when we try to treat cardiac arrhythmias. Also, when we have acid-base imbalances, conditions such as hypoxia, certain drugs, examples here, digitalis, and we're going to be talking about this drug today a little bit, or
Isn't that
next.
calcium blocker?
No, did you learn about digitalis at all? Yes,
Sodium potassium pump.
yeah, it is a sodium potassium pump inhibitor, and we'll be talking about it. أنا كنت ماسكته بإيدي بجرب. هلا سامعيني هيك؟ Okay. So digitalis or digoxin, we're going to be learning about it in much more detail when we talk about the lecture of what you think of heart failure. And we're going to mention it today just which kind of cardiac arrhythmia it's used to treat. But it's here present in the etiology or the cardiac causes of arrhythmia. So as we said, most of the antiarrhythmic agents are pro-arrhythmic. Also, digoxin has a special kind of toxicity or kind of arrhythmia that it produces, so it can cause some kinds of arrhythmia, but it's also used to treat other kinds of arrhythmia. Anesthetic agents, tricyclic antidepressants, and diuretics. هلا في mnemonic, it helps you memorize more of these names. A, B, C, D, and E. We're going to add to the A, B, C, D, and E anti. So the first one is antiarrhythmic. So the antiarrhythmic drugs are themselves pro-arrhythmic. It'll be biotics. So antibiotics drug. Who remember from last year course which kind of antibiotics can cause cardiac arrhythmias or changes in the ECG?
Macrolides.
Macrolides, excellent. So they are mainly the macrolides. هم azithromycin, clarithromycin. They can affect the QT interval. They can predispose to certain kinds of arrhythmias that we're going to be explaining a little bit later on. So A, B, C. شوف تخيلوا C هي شوية مش السايكليك. We're going to go to cyclic. It's
calcium pumping.
لا هي هاي السي شوي مختلفة. It's anti-psychotics. بس احنا غشينا استعملنا اللفظ تاعنا. It's written with a P of course, but just to help you memorize them. So some antipsychotics such as haloperidol, and you're going to be معلش الشباب اللي بيحكوا. We're going to be learning about these إن شاء الله بالcentral nervous system in the second semester. So A, B, C, D. D شو حكيت قبل شوي؟ Tricyclics. ليش يستعمل tricyclic? Depression. So antidepressants. And finally E. مين متخيل E؟ إيش أخذتوه بالفصل السنة الماضية يعني؟ Anti-emetic drugs. Excellent. So these includes the domperidone, metoclopramide that interact with the dopamine receptor. Okay? معلش الإيميتكس الأدوية ضد الغثيان أو المضادة للغثيان أو الاستفراغ. Everybody here speaks Arabic and understands Arabic. في ناس يعني لو أحكي هيك عربي you don't understand it. Okay. So we will try to keep it to English, and if I say something in Arabic, I'm going to translate it to English. Other drugs, bronchodilators or sympathomimetic agents, and we're going to go back to all of the sympathetic nervous system. All of the drugs that you learned with the sympathetic nervous system will be covered again with cardiovascular system. So why do you think the sympathomimetic system? Yeah, because they're going to induce which kind of receptor?
Beta-1.
Beta-1 adrenergic receptor to cause increase in the heart rate. So they're going to cause tachycardia. And we have normal reflexes, some GI reflexes, some neuronal reflexes. So the body's response to certain changes will also cause or predispose to cardiac arrhythmias. So what are the non-cardiac causes? We have ischemic heart disease, inflammation. معناها ischemic heart disease, it is kind of cardiac, but it's mainly related to the vasculature, not to the cardiac cell itself. Trauma, such as heart surgery. So some people, when they perform or undergo heart surgery, after the surgery, sometimes we have to put them on an antiarrhythmic agent to prevent the occurrence of cardiac arrhythmia, because we have messed up with the heart muscle. We might have done something wrong with the cells that can induce a electrical signal. Congestive heart failure, hypotension, electrolyte imbalance, and acid-base imbalance. في كمان
congestive heart failure بتكون سببها venous return increase.
هلا congestive heart failure, it's a long process. Where what happens with congestive heart failure? It's in the terminal stages of heart failure. We're going to be explaining these, but where we have stretching of the heart muscle, we have edema around the heart. That's why it is congested. Okay. So we're going to repeat some of the things you learned in physiology and build upon these to understand how the pharmacology is interacting with the normal physiological process or the disturbances of the physiological processes that occurred in our heart. So we know that the cardiac cell undergo depolarization and repolarization to initiate a cardiac action potential 60 times per minute, again from 60 to 100, and this is the normal cardiac rhythm or rate. The shape and duration of each action potential is determined by the activity of ion channel protein complexes in the membrane. One important factor, and I don't know why I didn't have it there, or maybe it's down there in the slide, here, genetic causes. So sometimes we have mutation in all of these ion channels, so either sodium, potassium, or calcium, and this can predispose a person to have cardiac arrhythmia. So inherited mutation, polymorphism, or acute ischemia, sympathetic nervous system stimulation, myocardial scarring, all of these can create an arrhythmia. And these are the different action potential that occur in different areas of the heart. We're not going to be reviewing all of these, but let's remember this is the SA node, and we have a bigger slide. We're going to talk a little bit about the different phases. Here, phase 0, 3, and 4. And remember, in the SA node, we don't have which phase?
Fast depolarization.
Fast depolarization, here 1, here upstroke, which is present in the other kind of cardiac cell. Here, this one, the overshoot, sorry. Initial overshoot. So what happens during an action potential? We have entry and exit of ions. So some ions enter to the cardiac cells, an inward current, and some of them exit. So here in this slide, it's showing us what are the different ions that are involved, ion channels that are involved in the cardiac cycle. So we have sodium, we have calcium, and then we have potassium. And let's here remember the pacemaker current, the IF. It stands for what, the IF?
Sodium.
شو الF يعني, do you remember? Funny channels. So, in funny channels mainly enter sodium and calcium, and they are responsible for the leaking of ions that is present mainly in the SA node. Hello, what are these? These are the genes that make these channels. This is the protein that is generated from these channels. We're not going to, of course, memorize any of these. But why is this important? Because as we said, sometimes we have a mutation in one of these genes resulting in a different protein. Now, what kind of differences or regulation does this mutation have? We have two kinds of function. Either it's a gain of function or a loss of function. So either the channel becomes more active or the channel becomes less active. So this is the SA node action potential. And remember, the phase 4, very important to remember that the slope of phase 4 of the SA node action potential determines the rate of the heart. So if we have increase in the slope, we have increase in the heart rate. And if we have a decrease in the slope, we have a decrease in the heart rate. Again, what is this under control of? Phase 4 is mainly under control of IF, اللي هم funny channels, that allows the entry of mainly sodium, but also calcium to the cardiac cell. بلش يصير عندنا, so we're going to have depolarization, sequential depolarization, until we reach the threshold. Then we have the depolarization happening mainly because of calcium entry. This is going to be opposed by potassium outward current, which is represented here in the repolarization phase. And if we compare this to the contractile myocardium, we note we don't have that upshoot. The upshoot is mainly happening in the contractile myocardium by opening of voltage-gated sodium channel. Why are they voltage-gated? Because they're going to be stimulated by the changes of the action potential that occurred in the SA node and the electrical conduction system before that particular point. What we want to know also, we want to remember that this dipping is associated by an outward current of potassium, and then the plateau phase is a combination between two ions. So potassium is going out and calcium is going in. Finally, the repolarization happens. The calcium channels are blocked or inactivated, and only we have the effect of potassium going out, and we go back to the normal resting membrane potential. We're not going to go into detail, although I think I have them in writing. I'll read through them quickly to make sure if I skipped any point that I want to focus on. We're not going to talk about all the physiology that you have learned. But one important thing I want you to remember, what is the resting cardiac cell, not pacemaker cell, action, what's the resting membrane potential? Minus 90, yes. Minus 90. So it is closer to which ion? Potassium. You've learned that in physiology? Yes, potassium is minus 94, and the resting membrane potential is minus 90. So the most important ion in regulation or regulating the production of an action potential is potassium. That's why we said if I have electrolyte imbalance, mainly potassium, for example, hypokalemia, this can disrupt this balance. What do I mean by disrupt? Do you remember Nernst's equation? Did you talk about Nernst's equation in physiology? So we're going to have a new number now, and this will provoke a depolarization of the cell and can cause a cardiac cell, a contractile myocardium, to become a pacemaker cell. And this is how, let's say, electrolyte imbalance can predispose to a cardiac arrhythmia. But also, potassium increase also can predispose to cardiac arrhythmia. It can cause bradycardia, but also it can cause tachycardia by reflex mechanism. We're not going to go in the details of these mechanisms, but we want to just know that potassium regulation is very important, or key point to understanding the normal cardiac cycle. And in the cases of hypokalemia, this predisposes to cardiac arrhythmia, mainly to tachycardia or tachyarrhythmia. Now, another thing I want you to remember from physiology, did you talk about sodium channel, how they exist in three forms? Yes. So we have the resting channel, we have the activated channel, and we have the inactivated channel. So the inactivated channel, what's the difference between it and the resting? That an action potential cannot occur or cannot be stimulated or provoked while the sodium channel is in an inactivated state. So now, why is that important pharmacologically? Because some drugs we're going to talk about, they like to bind, or they have higher affinity, remember that word from last year, for one form or one or two forms of these channels, and it have less affinity for another form. And this explains how these drugs are used in the treatment of cardiac arrhythmias. So here, this slide is kind of a, just to re-emphasize which kind of channels are involved in each phase of the SA node automaticity. We said in the phase 4, it's mainly the funny channels. In phase 0, it is phase 0, right? I'm لخبط بالأرقام. Yes. Yes. It is the calcium channel, and we said in the repolarization, it's mainly potassium channel. While in the action potential of a cardiac cell, that's not a pacemaker cell, remember we have sodium responsible for the upstroke. That's why a lot of the drug we're going to be talking about, they interfere with the sodium channel, so they're going to be changing the rate of upstroke, which will eventually change the rate of the action potential or the duration of the action potential. So in this phase we have mainly sodium. حكينا بالplateau phase it's mainly calcium and potassium. So just a little bit of revision again. The resting membrane potential, where we have a voltage difference of about minus 19 millivolts. It exists between the surfaces of the membrane of all cardiac cells. And we said this is due to uneven distribution of ions. Do you remember these numbers? You took them in the first year course. You probably took them last year for physiology and again this year. And we want to focus a lot on the sodium and potassium. It's very important to maintain these gradients. How are these gradients maintained in our body? Sodium potassium pump, excellent. And again, the sodium potassium pump, as I mentioned in the beginning of the lecture, is a target for one important drug that's pro-arrhythmic, it was with digoxin or digitalis, but it's also used to treat some arrhythmia. And we will be talking more about this sodium potassium pump when we talk about the treatment of heart failure. So let's talk about how an action potential is produced. When the cardiac cells are electrically excited, a sequence of voltage changes. We have depolarization and repolarization occur as a function of time. These changes in voltage are due to changes in conductance of ions. As I said in the beginning, sodium, calcium, and potassium across cell membrane. And this is the action potential sequence of events. We've already covered that. Phase 0, 1, 2, 3, and 4. What happens? Which ions are going to be changed or entering inward current and exiting outward current? Why do I keep saying inward and outward? When you look at the abbreviation of the ion channels, you're going to know some of them it's called IN and some of them it's called TO or OU. So that means an outward current. So we talked a little bit about the different kinds of cardiac arrhythmias. And we said one important thing I want you to differentiate is tachyarrhythmia is above 100, bradyarrhythmia is less than 60. We talked about the supraventricular arrhythmia, and we said supraventricular is synonymous with atrial. And what is supraventricular? It's tachycardia, it's above the ventricle. Now, remember the term sinus?
Yes.
So we have a sinus rhythm. What do I mean when I say sinus rhythm? What is the sinus? Let's say note. Sinus rhythm is the normal rhythm. But sometimes we have a sinus tachycardia. You're going to hear this term. What does sinus tachycardia means? We have an increase in the heart rate. It's as simple as that. We said a lot of time this goes unnoticed. It does not come up with signs and symptoms of the patient, so it's better to be left untreated. We talked about the terms fibrillation and flutter. So we have something called focal atrial tachycardia, multifocal atrial tachycardia. Focal atrial tachycardia, so we have an initiation of an action potential somewhere in the heart at one point. We have it at multiple points, we call it multifocal. We have atrial fibrillation, حكينا when we have irregularity in the ECG, so the time between each action potential and the other is not the same, it's an irregular. In this case, we call it fibrillation. So we have atrial fibrillation, which is something you've heard in books, in shows, على مسلسلات على التلفزيون, اسمعوا كلمة AFib. This is atrial fibrillation. And then we said, we have downstream, we have the ventricular. The ventricular arrhythmias are the most dangerous, which can be fatal.
مش VFib يعني high stops.
AFib,
VFib.
VFib, yes, excellent. زميلكم بيسأل VFib الهارت stop, it's very dangerous, it can cause death. Well, how do we treat VFib? VFib يعني ventricular
Push
fibrillation.
to the end.
Shock, this is the thing we can do. Now, if I have a person who is having history, but he survived, when I have a fibrillation, irregularity in the heartbeat, so some areas of the heart are contractiles, other are not. So the heart is not synchronized. What do you think this predisposes for? تخيلوا الheart, this is my heart, it's going like this. Here I have a contraction, here I don't, and then it starts. يعني يرجع لك الheart. Yeah, ischemia, something close. Yeah, infarction. What causes an infarction?
Torsion.
Blood clot. Excellent. كل اللي حكوا clots, more than a person said the same thing. So, what are we gonna give for these patients who have this problem? Anticoagulant. You talked about anticoagulant. So if I have a person who have atrial fibrillation or have ventricular fibrillation history, they have to go all the time on anticoagulant because they are predisposed to form clot. If the clot goes to the lung, we have pulmonary embolism. If it goes to the brain, we're going to have a stroke. So it's a very dangerous event if we have problems in the ventricle. It is less of seriousness, but both of them are serious if it's flutter rather than fibrillation. Again, flutter, it's more regular. So more regular means يعني less risk of development of a ischemia or a clot. Another thing we can have things in the conduction, حكينا ال AV node, and these are a term that we're going to talk about, and we're going to be able to cover it. في شيء اسمه AVNRT, atrioventricular nodal re-entry tachycardia. Let's talk about re-entry first. What do you mean by re-entry? We said I have a certain area in the heart where the action potential or the electrical signal or activation keeps going back to that point. So this is the normal circulatory pathway at peripheral Purkinje fiber. So we note here, there are branches here, we have a bifurcation, and the conduction will go towards the right and it's going to go towards the left, but we have this area. Usually under normal condition, we have the meeting of two opposing electrical conduction pathway that are equivalent in size, so they will counteract each other. So we don't have a problem. When we're going to have a problem, if we have a diseased area, so let's say I have a scar in the heart. Scar in the heart can be due to trauma, it can be due to surgery, or it can be due to previous infarction. So al-Marid, he had previous history of infarction, so I have a dead area there or ischemic area. So here, the conduction will not go normally. So I have this area being blocked. It might be not completely blocked, but what happens for the speed of conduction in that area, it's going to be slowed. And then in the other area, it's going to go faster. So we note here, in the unaffected or undiseased area, the action potential or the electrical signal will go around and come from the back for that diseased area. And we call that a retrograde pulse. We're going to hear that term in the future. We're not going to be talking about an anterograde. Anterograde going through the same pathway. Retro, it's coming from an opposing pathway. Now what happens, it's a little bit hard to explain what happens. Let's say I have that area of block and I have a division of the electrical conduction pathway. It's going to be slowed in one area, let's call that the alpha pathway, and it's going to be normal speed or a little bit faster in the other area, let's call that the beta pathway. Now, in the alpha pathway, yes, the conduction is slowed, but the refractory period is going to be shorter in order to try to adjust to that slowed action potential. So once my normal, once my normal impulse has gone, it's going to be able to reach that area and restart an action potential because I have a shorter, what did we call it? Refractory period, yeah, thank you. So we're going to initiate another action potential in the same area. It's going to go over and over and over, causing a circuit of event in that particular area. And this is what we mean. This is very simple, trying for me to explain what does re-entry rhythm mean. So re-entry rhythm occurs in different areas of the heart. It can happen in the AV node, and we call it a nodal tachycardia in that case, or it can have in other sites. It's called AVRT, re-entry circuit, AVRT, atrial ventricular re-entry circuit. I'm not going to be asking you about these subdivisions, but I have to explain them because these two categories that occur between the atria and the ventricle and occur because of blocks, either at the nodal level or in other tissue, are called paroxysmal supraventricular tachycardia. Both of them are called paroxysmal supraventricular tachycardia. And we're going to be talking about some drugs. Why do I have to mention that? Because I'm going to be talking about some drugs that this drug is used for the treatment of paroxysmal, اللي هي اختصارها SVT أو PSVT, paroxysmal supraventricular tachycardia. تقدروا تصوروا هاي الورقة if you're interested, but it's just my notes because it's a little bit complex topic. I had to just write some of these points in order to explain them. Re-entry circuit إلها اسم circus movement, where the impulse re-enter and excites the areas of the heart more than once. هلا a very important area condition رح تسمعوا عنها وموجودة شوي بالسلايدات اسمها Wolff-Parkinson-White syndrome. Have you heard of that term? مش Parkinson, it's probably the name of somebody who so Wolff, Parkinson, White are three people, I think, who discovered that syndrome. And this is again an atrioventricular AV node ventricular accessory block that causes a re-entry circuit. Something characteristic of that is we have a region in the heart. It's called the bundle of Kent, not the bundle of Hess. So when we have a re-entry circuit, can I move in circus or re-entry circuit at that area اللي اسمها bundle of Kent, this is characteristic of this kind of re-entry syndrome. شو هي هاي البندل of Kent؟ احنا بنعرف what's the function of the bundle of Hess? Is to propagate the conduction of the heart, the electrical conduction of the heart to the rest of the body. We have accessory pathways, so we have other pathways that can also transmit the electrical signal. They're not always functional, but when we need them, they become functional. And this is one of these accessory pathways, the bundle of Kent. Maybe you learned about it in anatomy, or no? Okay. So if we have a problem, a re-entry circuit in that bundle of Kent, we're going to have this phenomenon اللي هي اسمها أو syndrome, Wolff-Parkinson-White syndrome. And again, I mention these because I'm going to be talking about drugs that are used for the treatment of this condition. And I think we're going too slow. So this is the Wolff-Parkinson-White syndrome. It occurs at the bundle of Kent. هاي البندل of Kent هون. It's an accessory conduction pathway. معلش. أنا بعطي الورقة هاي خلي خضر يصورها ويبعث لكم إياها if you want to get all the information I have here. Some people ask me of the book. The book is again the same book we've been using for the last year اللي هو basically clinical pharmacology. المؤلف اسمه Kat Zong. I'm not going to be covering everything in the book. It's a little bit, especially بالbasic اللي هو physiology. They're a little bit expanding on it. What I want you to know is what's in my slide. For the drugs, I'll be trying to cover all of the drugs we have in the book. So if anybody did not understand anything here, he wants to go back, everything is present in the book. So what are the prerequisites for re-entry, which we call circus movement? We have to have an anatomical or physiological block or obstacle. We can have a unidirectional block. معلش ليه بنحكي؟ Everybody's talking. And as I said, the conduction time around the circuits must be longer than that effective refractory period, so it's going to be able to initiate another action potential in that alpha pathway or the diseased area pathway. You didn't talk about the normal ECG yet, but this picture, I'm not going to be explaining it. It's from your book. It's not even explaining the book. It's showing out the different kind of ECG changes we see with different kind of arrhythmias. This is the normal sinus rhythm. This is atrial flutter, and this is atrial fibrillation. We note here, look at the atrial fibrillation. This segment or distance between this S wave or the T, let's talk about the T wave. The T wave and the T wave is much bigger than this T and T wave. That's why we mentioned it is irregular. Sometimes we have changes in the P wave, sometimes in the T wave, sometimes we have disappearance in wave. When do we think we have disappearance in the P wave?
Atrial fibrillation.
Yes, when we have ventricular fibrillation or flutter. So because the ventricles start making its own activity, so we are not relying on the P wave. And here it represents what? Atrial depolarization. So this is a ventricular tachycardia, and we can see that we do not have a P wave here. So one last thing is a condition called torsade pointe. مين بيعرف فرنسي? What does the word torsade mean? Yes, it's a French word. Torsade means twisting of the points. So it means an arrhythmia. So we have these points of the ECG, they are being twisted or changed. It is a kind of ventricular arrhythmia that's very fatal. One important thing that is characteristic of this condition, the torsade pointe, is where we have long QT interval. And إيش بيميزها عن ECG, you're going to know that the patient have these long QT intervals. So we can see here, this is a prolonged QT interval. And the thing is, it doesn't show all the time, so we have to wait. And sometimes it's going to be normal. It's going to be ventricular tachycardia, yes. We're going to see the characteristic of ventricular tachycardia, but we're not going to be able to see all the time this elongation of QT interval. If we miss it, we're going to misdiagnose the patient. It's very important to try to diagnose the patient early on. And it's a fatal condition. It's associated with a genetic mutation in one of the channels. So these patients, if they know they have this condition, it's very important for them to take proper treatment. And the treatment for this condition is very easy. It's actually a beta blocker. So they can take propranolol before, of course, the attack or the arrhythmia occur. If it does occur, it can be fatal and it can cause sudden death. فإحنا كيف بنكتشفها؟ Somebody, if we have a young patient, and it happens usually in young patients, who just suddenly have an arrhythmia and he dies, all the siblings of this patient should go and do testing for that mutation to make sure that they don't have that mutation that's going to predispose them to this kind of injury. And if we found out that they do have this, we're going to start to give them the drug, beta blocker, which is going to prevent this from occurring. So we're going to stop here, and hopefully next time we're going to start talking about the drugs. Okay?